Hello and good evening. Welcome everybody to this session. In today's session, we will talk about the clinical reasoning, differential diagnosis, and red flags in MCCQ1 preparation, which are the critical and most important aspects of the exam. Uh, We know that everybody has a background in medicine. Many have even specializations, but and then they have the clinical knowledge. But what MCCQE1 expect is and or test is how you think in a clinical setting. And they will test the ability to move from patient's, presentation, how the patient is presented, what are the presenting signs or symptoms, and then go to differential diagnosis, how to prioritize differential diagnosis, and to identify the red flags, and also the safest next step. The next step can be a management, a treatment treatment component, or maybe it's an investigation or any emergency procedure. But the next step, and the main thing is that we should go systematically from patient's presentation to differential diagnosis, identify the red flags, and the safest next step, whatever it can be. And this is where the most candidates or many candidates lose mark, because it's not their knowledge. They have the knowledge, but if they don't systematically approach the question, then they will lose mark. But with the systematic approach, they will be more confident on most difficult MCQs in the MCCQ1 exam. Sorry, I had to admit some of the candidates. Yes. So in this session, we will talk about the systematic and Canadian focused approach to clinical reasoning, so that you tackle even the most difficult MCQs in this exam. So in this session, we will cover these topics, define the clinical reasoning, what is the clinical reasoning, and recognize the must not miss diagnosis, the red flags, which are the most important things, the link with the patient safety. Also, we apply the systematic approach to prioritize and identify and prioritize differential diagnosis, which differential diagnosis should be the first, which one should be the next, and so on. And we also will talk about the Canadian guidelines, because most of the figures come from the guidelines. And at the end, we will put all together to a case-based application. So what is a clinical reasoning? Clinical reasoning is the process by which we move from a patient's presentation to diagnosis, to management, and to plan everything. So it's not just recall the facts. The the things we just memorized. We have to apply the knowledge in a structural, logical way. Because the MCCQ1 test this skill, test clinical reasoning, but they test it through MCQs. So the clinical reasoning or the clinical decision making starts from gathering the information, which is through history and some the figures they provide through investigations like lab exam results, maybe an X-ray or an imaging test result. And based on that, we have to formulate our differential diagnosis. What diagnoses are in our mind based on these information. And accordingly, we must select the next best step. The next step, as mentioned before, it can be an investigation or can be a procedure, can be a management of the patient, can be treatment. So what we see here is that the first step is we have to assess for red flags and stability of the patient. Very important thing for the patient's safety. We have to see if the patient is stable because we can gather this information from the history provided or the presentation provided in the question stem. If the patient is unstable, we have to think about the red flags, and then we have to prioritize the differential diagnosis. If is it life-threatening? Is it common? Is it benign? And then we have to choose the best next step. The next best step can be to stabilize the patient. For example, the patient has hypotension. The patient has unstable hemodynamic. So the first step should be stabilize the patient, then we go further. Should we do any investigation like an imaging or a blood work or something like that? Should we treat the patient or should we refer the patient to, for example, you are in a office, the patient has an emergency condition, you have to refer the patient to the emergency room. So these are the red flags. What's a red flag? A red flag is a medical or a clinical finding that it needs or requires immediate action, or it raises a concern about a serious or life-threatening condition. For example, if a patient has a heart disease and the patient, for example, in ischemic heart disease, the patient comes with acute coronary syndrome and the patient is hypotensive. So this is a red flag. Or the patient with COPD has a low mental status. The patient's consciousness is compromised. This is a red flag, and so on. So it can be a serious pathology, life-threatening, and they require us to identify it instantly. Because this is a life-threatening condition and it needs an urgent management. So because of that, it's called the must not miss signs. For example, bleeding, for example, hemodynamic instability, uh, neurological deficits, focal neurological deficits, and things like that raise our concern about a serious condition in a patient, which is different in different clinical conditions, like for a patient with fever and stiff neck, then raises the concern about the meningitis. Sudden chest pain with dyspnea in a patient who was on a long haul travel raises a suspicion of pulmonary embolism. Things like that. These are the red flags, and these red flags should be in mind in every question. Okay, for example, now we check some red flags in different scenarios. In chest pain, pain at onset, how was the onset of the pain? The pain is maximal at onset. It shows something like an aortic dissection. From the onset, it's the most or in maximum pain at the onset. But as we know that the ischemic heart disease or a heart attack, the pain gradually increases. But when the pain comes just suddenly, it's something else. You have to think about something else. Then we can think about aortic dissection, which is a life-threatening condition. BP differentials, if there is difference in blood pressure in both arms, and it's more than 20 millimeter of mercury, we suspect aortic dissection. If there is pleuritic pain or the pain with which increases with respiration, then we can and when the patient has a precardial friction rub, we suspect pericarditis. The pain is exacerbated with exertion, radiating to the jaw or left arm or associated with diaphoresis, then we suspect acute coronary syndrome. If the patient has dyspnea and hemoptysis, and it's the onset is sudden, and the patient has pleuritic chest pain with it, then we suspect pulmonary embolism. The patient has dyspnea and chest pain with sudden onset of respiratory distress and hemodynamic instability. We may think about tension pneumothorax. So these are the examples of the red flags in chest pain. In headache, so if the patient has systemic symptoms like fever, weight loss, and malignancy, these are the red flags. The patient has headache, and these symptoms, the systemic symptoms, it can be a serious condition inside the skull, maybe a tumor, maybe infection. If there is neurological symptoms with the headache, it's also a red flag. For example, the patient has confusion, the patient has focal deficits like hemiparesis, maybe speech problem, vision problem, then it's a red flag. If the headache has a sudden onset, it's also a red flag. For example, a thunderclap headache in subarachnoid hemorrhage, which is a life-threatening condition. New onset of headache after 50 years of age is also a red flag because it can be a sign of malignancy. A pattern change, the patient had some a pain like migraine or tension headache, but now the patient has another kind of headache. The pattern is changed, or the symptoms are become worse or progressively worse, or new headache or new type of headache appears. They are the red flags in headache. So these symptoms like headache, chest pain, these are the most common symptoms that are commonly tested in the MCCQ exam. For example, in a back pain, how we identify the red flags? We have to assess bowel bladder dysfunction. The patient has a back pain. We have to see if the patient has a bowel bladder dysfunction. If there is bowel bladder dysfunction, it points to cauda equina syndrome, or the patient has subtle anesthesia or bowel bladder dysfunction at the same time. It's cauda equina syndrome, which is an emergency case. If there is neurological deficits, it's also a red flag. Progressive neurological deficit, like in motor and sensory, both or either, it's a red flag in back pain. Age also can be a red flag in older people or in younger people. When there is a severe back pain, we may suspect malignancy or infection. And in back pain, we have to review the history of cancer, fever, IV drug use, because all of them can affect our diagnosis and management. So red flags in dysphagia and constipation and gastrointestinal symptom. When the symptoms are progressive, for example, in dysphagia, the patient has progressive symptoms from solids to liquids, then to everything, accompanied by weight loss. We suspect malignancy. If the symptoms are intermittent and it's not progressive, then it can be a sign of benign condition. We have to think about alarm symptoms when it's new onset, it's progressive, and accompanied with weight loss and bleeding. They are the alarm symptoms for gastrointestinal conditions. But when the patient has the constipation without specific progressive or systemic alarm features, then it can be a benign condition rather than a malignant condition. And in general, systemic red flags, for example, weight loss, it can be due to malignancy, can be due to chronic infection, can be due to malabsorption. If the patient has unexplained anemia, it also can be a GI bleeding, it can be malignancy, it can be nutritional deficiency, if the patient has fever and night sweats, it can be infection like tuberculosis or lymphoma. If the patient has hemodynamic instability, then we may suspect sepsis, hemorrhage, dehydration, cardiac event. And if the patient has persistent vomiting, we may think about intestinal obstruction or increased intracranial pressure or a metabolic cause. Any of them can cause persistent vomiting. And based on the history presented in the question stem, we can come up with some differential diagnosis, and then we can choose the next best step, whatever it can be, treatment or diagnosis or investigation. So now, here are two scenarios. One scenario is a 55-year-old male with sudden severe headache, maximum intensity in seconds. The patient doesn't have any fever, and the patient doesn't have any neck stiffness. What do you think? What differential diagnosis should be in our mind when we see this kind of scenario? What are the red flags? Can anyone identify the red flags in the first scenario?
Sudden severe headache.
Thank you. When there is sudden severe headache, maximum intensity in seconds, it's a red flag.
And if it's also associated with vomiting, like excessive vomiting.
Yes. Thank you. When it's associated with other red flags, it becomes more severe, and it helps us to identify the main cause. There's the other scenario is 70-year-old female, new onset low back pain, history of breast cancer 10 years ago. What are the red flags in this?
History of breast cancer 10 years ago, and also new onset low back pain.
Thank you. So we have any other red flag?
Neurological deficit.
Yes. I mean, in this scenario, just
The first one.
The
the
age.
second one. Yeah.
The age of the patient.
Age of the patient. Yes. The patient age is a red flag. It's an advanced age. Okay. New onset and history of breast cancer. We have 3 red flags in this scenario. So this is how we identify the red flags, which are the most important parts of a question stem. Then based on those, the information given to us through the history and the investigations, we should build our differential diagnosis. And we start from the most probably diagnosis. The first differential is the most probable, and then we have to have at least 1 or 2 more differentials in our mind when we see the options, then we can choose the proper or the correct answer or the correct diagnosis. So the differential diagnosis is organized by urgency and also the likelihood. Which one is most probable, or which one is more urgent, based on the red flags. So first we have to list the must not miss diagnosis in our mind. Is there a life-threatening condition? Treatable conditions that require immediate attention. These are the most important differential diagnosis that should be in our mind. Then we think about the common diagnosis, because most of the questions ask about common diagnosis. Then we in the differential diagnosis, the most common ones should come first in our mind, based on the history and the investigations. Those conditions which come based on prevalence, how prevalent they are. And this is that when we come to the diagnosis, then if the question is about next step, then we can properly choose the next step. It can be an investigation, can be a treatment, or a procedure. But first we have to diagnose. You have to come up with the diagnose, and then we can choose the proper or the correct answer. And sometimes there are some rare diagnoses as well that should be in our mind when we come up with the differential diagnosis. So we see that in differential diagnosis, we have to think about three things. First, the most dangerous ones, life-threatening ones, must not miss diagnosis, then the common ones, then the rare diagnosis, which are uncommon but possible. Then this is how we will not miss the correct answer in the questions. So for that, to come up with a differential diagnosis, we should use a system-based approach. Based on the clinical symptoms, we come up with the differential diagnosis, and we have to do it system by system. For example, in cardiovascular system, okay, there are systems like chest pain, shortness of breath. It can be acute coronary syndrome. It can be aortic dissection. We have to, so the most dangerous ones, life-threatening ones, these are the most important that we have to think about them. These are the must not miss diagnosis. Other diagnoses can be pericarditis, myocarditis, but we have to think about the most serious ones first, then the common ones, then the rare ones. In respiratory system, the patient may have cough, difficulty breathing, which can suggest pulmonary embolism, pneumonia, okay, pneumothorax, pleuritis. They should be based on classification of the most dangerous, must not miss, and the most commons, and also the rare ones. In gastrointestinal system, the patient can have a heartburn or difficulty swallowing, which can point to GERD or esophageal rupture, esophageal carcinoma, maybe esophagitis, peptic ulcer disease. We have to think about all three categories in every system. Musculoskeletal, there can be chest wall pain or tenderness due to costochondritis and muscular strain. And when we come up with a differential diagnosis, if it's chest pain, we have to first think about the most dangerous ones in cardiovascular, in respiratory, and as well as musculoskeletal and also gastrointestinal. All of them can cause chest pain. But we have to have a broad mind and think about the most common ones based on the presentation. Okay, so these are the must not miss diagnosis by system. It's a quick reference, it's a quick example. For example, in cardiovascular system, acute coronary syndrome, aortic dissection, tamponade, cardiac tamponade, these are the must not miss diagnosis. We have to think about this diagnosis when there is chest pain or in cardiovascular system. In respiratory system, pulmonary embolism, tension pneumothorax, massive hemoptysis. These are the must not miss diagnosis in respiratory system. In gastrointestinal system, bowel obstruction, esophageal rupture, cholangitis, GI bleeding. These are the important must not miss diagnosis. In neurological system, subarachnoid hemorrhage, meningitis, Cauda equina syndrome, stroke. These are life-threatening conditions that must not be missed. In endocrine system, diabetic ketoacidosis, adrenal crisis, thyroid storm are among the must not miss diagnosis that should be in mind in every situation. And here are some Canadian guidelines and clinical reasoning. And most of the figures in diagnosis and also in treatment come from these guidelines. And these guidelines are updated, most of them updated yearly. For example, in Diabetes Canada, HbA1c less than 7%. The target is 7 or less than 7% for most adults. And we have to protect cardiovascular and renal systems in patients who have diabetes. And for renal and cardiovascular protection, we give the patients SGLT2 and inhibitors and GLP-1 receptor antagonists to protect cardiovascular renal system. This is in Diabetes Canada guideline. In Canadian Cardiovascular Society guideline is used for we use it for acute coronary syndrome and atrial fibrillation management. For example, the score of CHATS 65 for atrial fibrillation, how to choose anticoagulation for the patient based on the score. And also there is another guideline, Choosing Wisely Canada, is about imaging, how to choose imaging for the patient, because over prescription or advising imaging for conditions that don't require the imaging is also regarded as incorrect. So when we see a question, and the question in the stem, there are no indications for any imaging, and we choose, for example, MRI or CT scan or any other imaging which the patient doesn't require, then we will lose mark. And Choosing Wisely Canada helps us in this regard. How to prescribe an imaging investigation for a patient with back pain, for example. And if the patient doesn't have a red flag, then the patient may not need imaging as investigation. So in Choosing Wisely Canada, there are guidelines for low back pain, for blood tests, for chest X-ray, ECG screening, for chronic pain, for acute sinusitis, for which patient we should give antibiotics, for which one we shouldn't give antibiotics, which patients require screening, chest X-ray or ECG for, on which patients do not require that. For example, the patient doesn't have any symptom, they will not require any chest X-ray or ECG screening. Blood test as well. If the patient is asymptomatic, the patient is healthy, there is no need to do annual screening for blood tests. Low back pain without any red flags, they may not require any imaging. And for chronic pain, if there is no cancer pain, we should not give the patient opioid painkillers as a first line. These are the examples of the guidelines that are present in Choosing Wisely Canada. And guidelines are important because they are updated yearly. And the figures and MCCQ1 questions take their figures from these updated guidelines. So here is another clinical reasoning case. We have a patient, 62-year male patient, sudden worst pain of my life, chest pain radiating to the back. The patient has blood pressure on right arm 110 to 70 and left arm 90 to 60. So what is the most likely diagnosis based on this presentation?
aortic dissection.
Thank you. Anyone else?
Yeah, it's aortic dissection, as there are many red flags on the scenario, like
Yes.
the age,
Okay.
sudden worse pain,
Yes.
and also the difference between the blood pressure in the left and right arm is almost 20 milligram of mercury. So it is
Yes.
suggestive of the aortic dissection.
Yes. Thank you. So we have the red flags and we have the scenario, so we can think about the most likely diagnosis. And what is the next best step in this patient?
So the first step is to stabilize the patient.
Yes.
And then second is to perform X-ray.
Yeah. So we can based on the patient's hemodynamic status, because this is an emergency case, either we can we have to stabilize the patient, we have to lower the cardiac rate, and also we have to do the imaging to confirm the diagnosis, and then you have to send the patient to surgery. Sometimes when the patient is unstable, we do not have time for imaging. The next best step is to send the patient to the operating room. So it can be based on the clinical scenario. It can be a CT angiography, which is the gold standard to diagnose aortic dissection. And also, if the patient is stable, we can give the patient a beta blocker, a labetalol or something to stabilize the patient, and then we can send the patient to imaging and then operating. So the next best step, when we have the diagnosis, then we can think about the best next step according to the our diagnosis. So this is the clinical reasoning pathway. It has 3 steps. The first step is identifying the red flags. We have to assess the patient's stability. Is the patient stable? And the warning signs, what are the warning signs? Like the red flags we just discussed in the previous slides. And also the medical history of the patient. We identified the red flags here. After that, we will prioritize our differential diagnosis. What are our differential diagnoses? From the system itself, from the adjacent system, for example, is cardiovascular system, the respiratory system, and also gastrointestinal system. We categorize the diagnosis into must not miss, common, and rare. And then the final step or next step is we select the next best step. What is the best next step? It can be stabilize the patient, it can be a procedure, it can be an investigation, it can be a referral. For example, in the case of aortic dissection, or based on the presenting illness and the symptoms and the patient's vital signs, we may send the patient to imaging or directly to the operating room. So here are the common pitfalls on the MCCQ exam. Missing a red flag. Missing a red flag is one of the common pitfalls. Is a frequent error, and it costs the IMG a mark. For example, if the patient has weight loss and anemia and we do not notice it in the question stem, then we may just completely we may go to another direction. We will not have the proper diagnosis and differential diagnosis. So when we do not have the proper diagnosis, then our next step will be wrong. The next step we will not choose the correct answer from the options. Another pitfall is using non-Canadian guidelines. The figures may differ from US or UK guidelines than Canadian guidelines. Canadian guidelines have their own figures, definitions, and for example, in screening. In the United States, for colon cancer, they do the colonoscopy from age 50. But in Canada, in a person without any family history of colon cancer, they will do the FIT test. They will not. They will do the stool test for blood, and if it comes positive, then the patient is sent for colonoscopy. But in the United States, they will send the patient directly to colonoscopy. If we choose for example, the screening, the scenario is a patient 51 or 52 years old patient, and they ask about what screenings, and if we choose the colonoscopy, it will be a wrong option, because in Canada they will not start from colonoscopy, they will start from FIT. And therefore the Canadian guidelines are important if we want to write the MCCQ1 exam. Ordering unnecessary tests. If the patient doesn't need any, the patient has for example, the patient has a low back pain. The patient is, for example, 35-year-old male, and the patient has back pain after, for example, shoveling the snow, and the patient doesn't have any red flags, and we order MRI for the patient, that's a wrong option. This patient doesn't need any imaging. And one of maybe a common mistake is not reading properly the last line of the question, which is the most important one. For example, it asks about the management, but we select a diagnosis. This has happened frequently, and we should read carefully the last sentence, the main question. The question has two parts. One is the question stem, which they provide the background. For example, the age of the patient, the symptoms, investigations. We find red flags, everything there. And there is then the main question. Either it's what's the next best step, or how you manage the patient, what's next best step in diagnosis or in investigations. So we have to read carefully the question, the question stem and the main question sentence, which is in my opinion, it's 50% of the question. If we know it, we know 50% of the question. If the other 50% is the background of the patient. And both are important to come up with the differential diagnosis, to identify the red flags, and then know what is the next best step. So what are the questions come in your mind with all this information I gave you today? Is there any question about red flags or building a differential diagnosis, Canadian guidelines, screenings? So the most important thing is that we have to use the standardized protocols, which come from the guidelines. And Dr. Sebsoila, you had a question?
Yes.
Yes.
If we don't have this slide, we will forget all of this. Would you send us this slide?
This is the complete video is recorded, and they will upload it to in the Jala Academy site, and you can download the video and play it as much as you want. Then you can.
But the slide is better than video, I think. We can always.
I send the slides to Dr. Sebjola, and they will manage it. They will if it's the policy, they will put it in the site as well. Yeah.
Thank you so much.
Yeah, you're welcome. So one of the most important thing in preparing for the exam is to be familiarized with the guidelines, Canadian guidelines, because they present updated recommendations for every condition. For example, what kind of investigations are required, or what are the indications for example, for MRI in a patient with back pain, or figures about diabetes, how you define the diabetes, or what are the targets of, for example, HbA1c in a patient with cardiovascular system disease with diabetes. These are the things that are updated yearly, and we can find them in the Canadian guidelines. And another thing is diagnostic certainty. We have to, from the information we get from in the question stem, we should be certain about the diagnosis. And sometimes the question is how to confirm the diagnosis. Sometimes the question is what is the gold standard for the diagnosis. Sometimes the question is about the management. And we have the gold standard diagnosis in the question stem. For example, they gave us the investigations, and among the investigations, there's the gold standard as well. For example, the patient has MRI. The patient has radiculopathy, and they gave us the MRI result as well. Or the patient has some condition like the patient has a tumor, and they will give us the biopsy result. So we have the confirmed diagnosis. We do not need to confirm the diagnosis. Then the next step will be a management. So we have to read carefully the question stem, because we may find red flags in it. We may find the diagnosis or the gold standard investigation to diagnose the patient. Everything can be there, and accordingly, we have to choose the best next step. We have to assess the general condition of the patient. Is the patient stable? Is the patient unstable? And also urgent screening, identifying the critical must not miss conditions. And the screening, we may use ECG, we may use X-ray, some blood work to come up with the diagnosis. So this is the toolkit for clinical reasoning. In every question, we have to scan for red flags. In every question, we have to scan for red flags. We have to see if there are any, what are the red flags in this clinical scenario. Then we must prioritize the must not miss diagnosis. We have discussed it in the previous slides, and they show clinical safety. Must not miss diagnosis means life-threatening conditions, and if we miss them, we jeopardize the patient's safety. And this will be a big mistake in any question. Another thing is we have to know the Canadian guidelines, because every year they are updated, and the figures and the protocols come from these guidelines, and the questions in MCCQ1 reflect those guidelines. These are Diabetes Canada, Canadian Cardiovascular Society, Choosing Wisely. These are the most common ones. And the next best step, it's not always the diagnosis. It can be an investigation, it can be a diagnosis, it can be a treatment, can be a referral, it can be any of those. And because of that, we have to read the question, read the options carefully. And with practice, we will be able to read carefully the question in, for example, 48 to 50 seconds. They will give us about 1 minute and 10 or 15 seconds for each question. But with more practice, we will be able to read it in less than a minute. And our goal should be that. Our goal should be to be able to read the whole question in 48 to 50 seconds, so that we will have time to choose the proper or correct answer and be confident that we have chosen the correct answer. So this is the last part of our lecture tonight. I have to emphasize that the clinical reasoning is at the heart of MCCQ1. It's the most important thing. If we use it in the exam, we will definitely pass, because there will be no room for any mistake if we just go systematically. We use the red flags, the differential diagnosis, and then we can choose the best next step. I know everyone has that knowledge, but with these practices, we can adapt ourselves to the Canadian system and how they expect us to perform in the exam and in the real clinical life. You have to have confidence in your clinical reasoning skills. When you practice, your confidence and your clinical skills will improve. And you have to apply a structured approach to diagnosis. You can consider the critical diagnosis, which we should not miss. The ones that are life-threatening, and if we miss them, the patient's life will be in danger. So the must not miss diagnosis should be in our priority. And red flags first. We have to identify the red flags, especially the life-threatening ones, first in the clinic, in the clinical scenario. And these are the resources for preparing for this exam. The primary reference can be Toronto Notes. You can use practice questions, which we will provide you the questions every night. We will have a review of the topics which you have which you have in your schedule. We will review the cases, the topics, and then we will practice the questions. This will give you a good idea about how the questions are in the real exam. And then we will have some mock exams for you. So you will see how how prepared you are for the real exam. And there are some guidelines you have to consult with those guidelines. I recommend you at least once you read those guidelines because they are very important. And the main thing is that they are updated yearly. And you can have official information from Canadian Medical Council site, because sometimes some regulations change, and you can only know through their official website. So I recommend that you, from time to time, check Canadian Medical Council site to see if there is any update or any change in any regulation or any policies in exams or any other requirements for the IMGs. So this concludes our tonight's session. If you have any question, I'm at your service. We will have our practice questions and reviews from the next week.
Excuse me, Dr. Weiss. I have a question, but it's not related to today's lecture. So, how long it took for you to get your credential recognition?
Well, credential recognition, it depends. My one was maybe 45 days, something like that. And it was because I had verified my documents through for another exam. They had everything, I think, ready in the medical university. And when MCC sent for verification, I think they had it and they sent it. But some people, I hear that they have waited for 3 to 4 to 6 months.
Okay, thank you.
Yeah, it depends on the country. It depends on the medical faculty. It really depends. Any other question? Dr. Sneha?
Hi, Dr. Weiss.
Hi, how are you?
I'm good. How are you?
Is there any question, any feedback?
Not so far. Maybe next week we will be covering cardiovascular.
Yes, cardiovascular. I think you all of you have the schedule, yes?
Yeah, we do.
So yeah, we will go according to the schedule.
Okay.
Yeah, because you will read before the session. You may prepare yourself. You may read something based on the topics on that day, so that when we review it will be more beneficial for you if you just read it beforehand. Mr. Qais,
Yes, sir. I have just one request.
yes?
Could you please put the slides after the class in the WhatsApp? It is easy to access for me.
Well, I send this to Dr. Jala because they have their policy. I will send everything to them. We have recorded this session, and they will upload the whole session in Jala Academy site. But
Because
I
every
think,
time it takes
yeah,
too long.
yeah, I know. And I think you better ask Dr. Jola about this because they have the policy, so we are not allowed to
For sure.
share these
Thank
things.
you. Okay, thank you.
Yeah,
Thank you. I will
I
ask.
hope you understand.
Okay, okay. Thank you. Thank you. I know. Thank you.
Dr. Wise, we are trying our
Yes,
best to upload everything within 24 hours. There was
yes,
some technical problem, but furthermore, we'll be uploading within 24 hours
yeah,
now.
of course, yes. For the last session, you had a problem with uh, downloading the material, but these sessions will be uploaded just uh, within 24 hours. Don't worry about that. Dr. Sarah, you have a question?
Sorry, this question, of course, maybe I can ask from Dr. Sinha. In the WhatsApp group that we are, there are a lot of people that are not right now registered by you and by Academy. Would you please, for example, create some WhatsApp group for 14 people who are right now here to be in connection with each other?
So basically, you want me to create a WhatsApp group where the
Yeah,
current
for
students
us,
are.
for us, we are right now, we are, I don't know, 12 people, I don't know,
So,
13 people. Uh,
mhm.
but the WhatsApp group that we are, in it, there are a lot of people, and most of them are not registered by you. I don't know, can you remember
Yeah, I understand,
that
Dr. Sarah.
they were
Actually,
added? Yeah,
yeah, actually, we for this batch
it
we
is in
have
your
around
policy.
35 students. So I'll talk to Dr. Jwala and probably
Thank you.
create a new. Okay.
Thank you so much because we can ask each other and Dr. Jallo can see it and
Yeah, yeah,
it's
yeah.
I think it's a good, yeah, thank you so
Or
much.
maybe I'll be just creating now, and then if possible, we can add many people, because for me, I'm also not aware of many people name. So I need to take help of you or Dr. Jwala.
Okay, thank you so much.
Dr. Nicole?
Yeah, I'm just agreeing with what the doctor said. It will be good we have a closed group just for those that are really following the lectures so we could communicate easily.
Okay, it's
So
for
what
you,
I
Dr.
see
Sneha.
here, there is a group which is July 2026. It is just specific for this batch only. I can just say hello in that group. So if you can take a look, if any of them you are not here, you can just let me know. I can add you. But this is only specific for this batch only.
I think I'm not in this group that you are mentioning.
Okay, Dr. Sarah, may I know in which group you are there so that I can add you, or you can message me so further I can add you.
Okay, thank you so much.
No problem.
I'm in Java Academy IMG and the other one Knock-Axie. But okay, I will message you. Thank you so much.
Okay, no problem.